Welcome everybody that's new. We're going to start in just a couple of minutes. I am Julie Lemoyne. I'm going to be your moderator today for this wonderful talk. For those of you that don't know me, I've been working for more than 15 years in applied XR, and I've worked with a number of organizations, more than 25 organizations. Currently, I am doing fieldwork in applied XR at the University of Massachusetts Medical School at the Eunice Kennedy Shriver Center for where they focus on autism and other intellectual challenges. And I'm doing part of my research there for my PhD that I'm getting at the University of College in Dublin. I am actually an Irish Research Council Scholar, which is a prestigious scholarship that I'm very lucky to have. So welcome, welcome, welcome. I have a little bit of a cold. Hopefully that doesn't bother people in the audience. All right, so for those of you that I know people are going to be coming in while we start the beginning here, I want to try and keep us on track just a little bit. So I'm going to talk just for a moment about what MedVR is. It's a pretty new organization. We are a community centered around sharing knowledge about the development of new applications and using augmented reality, which we're going to talk about today, virtual reality, mixed reality in healthcare. So our mission really is to seed community of healthcare professionals, all types of professionals from the clinical and medical side to designers, technologists, and artists. And that's such a diverse community. We're trying to bring them together and sort of raise all boats so that we all learn about the future of this technology and create new innovation. And along those lines, if you're interested in knowing more about MedVR, there's two things. One, our next talk, which I'll talk about at the end, is going to be on October 21st, and we have a number of our fellow organizers who will come together on a panel and do a deeper dive, and they will talk about our goals. And we have an educational curriculum starting next year in January, so they're going to talk about that, and that's amazing, and it's free. And then our hackathon in 2021. So we really are trying to grow this unique and very diverse cross-discipline community to build expertise and knowledge, and this does not happen without some help. And so I just want to throw a shout out to our sponsors. And if your organization or you are interested in sponsoring, I really encourage you to reach out and give us your dough or sponsor us in some way in the hackathons that are coming and other things. Okay, so I'm going to stop these slides, and so you can see our speakers for just a moment here as I make their introductions. But a reminder that the chat is there for you to talk to the other audience members, and we have a number of the MedVR experts that'll be there. If there's questions that they can round up, they will. And if you have questions for our amazing speakers today, please put them in the Q&A tab at the bottom of your screen, and we'll go over those at the end. So let's see how we doing with, we need to give it just some time for people to show up. I don't want to make too much of an introduction. All right, but I will start. So it is my great pleasure to introduce Dr. Johnny Duerinck from Brussels. He is a neurosurgeon and an innovator fostering the use of AR in neurosurgery. His work at the University Hospital in Brussels concentrates on both the surgical and non-surgical treatment of brain tumors, and he's been doing that since the beginning of his work there. He has also spent significant periods of time in other centers in Montpellier and in Milan to learn techniques that are used to operate on brain injuries that are located near functionally important brain zones. He's interested in complex spinal neurosurgery, and that is both minimally and open technique, minimally invasive and open technique. And he is a professor as well. So we are very lucky to have him today. He's a trailblazer. And we also have Dr. Bart Jansen, who is a professor at the Department of Electronics and Informatics at the Vrije, I'm going to say that wrong, I know, University in Brussels. So please feel free to correct me when you come on. And he's been a professor there for many years, and prior to that conducted postdoctoral research for 9 years. And Dr. Jansen also consults with organizations in areas of computer science such as AI, XR, and other areas. Both have given me permission to call them Johnny and Bart, as opposed to their official titles. Only their students, I guess, have to call them professor. But I want to thank you both so much for being here. We know you're both very busy. Once again, folks, please, if you have questions as we go through for the speakers, put them in the Q&A, and then just feel free to enjoy each other in the chat. As you can imagine, these two experts have a lot to share with us. So what we've done is we've broken it into 3 10-minute sections in hopes that we can enable them to cover the topic really well and then give us plenty of time for Q&A after. So the way that we're going to proceed is the first 10 minutes we're going to have Johnny talk about the collaboration that he and Bart formed and how it evolved and why it started and how he got to now. And then we're going to have Bart talk about the technology of it all and what they've done with their collaboration and the technology from start to finish and for now. And then the third part, really exciting for those of us that are research scientists, is that Johnny is going to cover some portion of the 2 upcoming studies that they're going to be publishing about impacts and outcomes and the use of their techniques. So that's really exciting for our audience. And then we'll end it with plenty of time to do Q&A. So I will do my very best to keep us gracefully in the sort of 30-minute time frame for the 3 areas that our experts will be talking about. We're so lucky to have them. And then we'll kick off about a 20-25-minute period where I have some interesting questions that I would like to ask them, and then we'll move into audience questions. So without further ado, I really would like to hand this over to you, Dr. Johnny, and let you take over the screen and bring us there on how your collaboration with Bart and in this area started and how you've gotten to now and what prompted all of this and the whole collaboration journey, if you will.
Okay. Thank you, Julie. So is my microphone fine? Are you hearing me?
Yes, you're fantastic.
So thank you, first of all, for having us and for the kind introduction as well. So let me just pull up my slides and then we should be all good to go. So as Julie just said, I would like to first just go over the way this whole project, which we called Surgical Augmented Reality Assistance, or SARA, came about. So since I was, I've always been interested in games and in computer games and computer development, and you know, at a certain point in time you need to make a career choice and you need to make a study choice, so you go for medicine. But I've never lost my interest, I must say, in these sorts of things. And maybe this is one of the reasons why I also dwelled into neurosurgery, which is a more high-tech domain than most are. And I must say, I was always a bit disappointed that the graphics, if I could call it like that, that we use to look at patients are quite inferior to what you see in most modern games. Even 10 or 15 years ago. So I always had this idea that it could be better, that rendering could be better, that the way of being provided these images could be better. So this is how this whole project came about. So when you look at how most surgeons navigate through their surgical field, so initially it was mostly based on anatomical knowledge, and then you go inside the patient and you try to make out what's normal anatomy and then see what's pathological and then take that out. Of course, you can do CT scan, and more recently you can even do 3D reconstructions to prepare you even better. But still, once you're looking at the patients or once you're inside the patient, then you still have to make up your own mind. Now, in neurosurgery, it's mostly used, let me just turn off the sound. There we go. Wait. Yeah, so the sound will be playing here. I hope it's not too disturbing. But in neurosurgery, we have a way of coupling the images that we have made of the patient beforehand to the patient in his actual position in the OR. This is called a neuronavigation system, and it allows us to first register the patient. This is a procedure that you see sped up here. And then using this pointer device, you can hold it in any place, even inside the anatomy of the patient, and it will show you where exactly the tip of your pointer is located. So this actually couples the images that you make preoperatively to the tip of the pointer device, and it's extremely helpful, of course, for most surgical procedures, to that extent that it's used everywhere. In every neurosurgical department, this is something that they use. And this is something that I've known since the beginning of my training even, but I've also seen a lot of flaws with it in the way that it works, and also in the way that it's providing this information to you. So first of all, the devices that you use are quite bulky. They take up a lot of room in the OR. And also, if you would want to use it for more, let's say, smaller procedures that you do outside of the OR, like in the emergency room or the intensive care unit, then you would not transport it and thus not use it, even though it can have its usability there. So that's one limitation. A very important limitation to me is the fact that you're looking at a screen instead of actually looking at your patient. So this way, there's really, it can cause a problem with hand-eye coordination, but most of the time what you actually do is you stop operating, you look at the screen while you hold your device, and then you look back and you try to merge this information that you just got from the system to the actual patient's anatomy. So to me, that's also a big issue. But what I feel is the most important thing, it's not only the fact that you're actually looking at the screen, is the fact that what you're looking at is like this image that you see on the top here. It's actually a slice-based image, and you can provide it with a 3D image, but this doesn't move like the patient moves, and it doesn't adapt its position to your head position. So this means that you have to do a lot of mental work. It's a huge cognitive load to transfer this information to the patient itself, and to how deep you still have to progress to, for example, remove completely a tumor. Then also there's a line of sight problem. This means that the device uses a camera which needs a direct view of the patient and the tracker, which is often blocked by stuff in the OR or people in the OR. So this is also a problem. And then one of the main issues that's not immediately solved, I must say, and not with our current project either, is the fact that you're actually using images that are done before surgery. So as soon as you change the anatomy, by definition, everything is changed, and you need to take this into account, or you need to develop systems that automatically update your imaging, which is currently not yet commonplace, let's say. So actually, if you summarize the consequences of these limitations, it's that, like I said, the navigation is not used for some simple procedures that are performed inside or outside the OR. One typical example is the placement of ventricular drains, which we always do according to certain anatomical landmarks that we use. So we take a certain distance in front of the coronal suture and from the midline, and then you target towards medial part of the eye and part of the ear. And this is standard. It's really commonplace everywhere in the world. And using this technique and taking the results from a whole lot of studies together, you can see here that actually only 4 out of 5 drains is correctly placed if you use this so-called freehand technique. So these are really, this is quite a good result. And if you place 4 out of 8 out of 10 drains correctly, then, you know, any surgeon would say that's actually a good result, but it's still not perfect. It means that about 20% of cases you misplace these drains. So that's not the ideal situation. It can be improved upon. So that's one limitation. Another limitation is that more complex procedures like spine procedures, it's not used there often either because of the need for supplementary tools. You need per-operative imaging devices to do spinal navigation, because the spine moves as soon as you turn a patient in the prone position for the surgery. And then, of course, looking at the screen part, the ergonomics are still lacking due to the mental work that's required when using it. So you need to always transpose in your head the slice-based information on the screen to the actual patient, which remains quite difficult even with many years of experience in this respect. So these are the limitations that I always had in my mind. So I always thought, well, this can be better. And when Microsoft launched its HoloLens in late 2015, early 2016, I immediately had the idea that this could be a solution for such a problem, because if you present the information as a 3D image correctly positioned in the 3D space where the actual anatomy is located, it could solve some of the problems that I listed there. So I always had this in my mind, but of course, as a neurosurgeon, you're deep in clinical practice, and you're not always looking for new developments or looking for colleagues who can do this. But then our university, which is the Vrije University of Brussels, tends to organize on a yearly basis, at least before COVID, this was the case. But anyway, on a yearly basis, some day of science, they call it. And so it's where just the main public can just come over and then look at, you know, everyone that's involved in technology. And I think it was the year 2016 or maybe 2015, I'm not sure anymore, where we actually had a stand with our neurosurgery department. And we demonstrated the neuronavigation, and we showed it to the whole public. And then as I was wandering the other stands that was there, I met some people that were linked to the ETRO department, to a separate department called Robotics that's concerned with robotics. And he's a business developer, and I talked to him about my idea and my issue, and he, you know, he stood there really thinking about whatever I was saying, and he told me, well, okay, let me get some people together and we'll see what comes out of it. So then we set up a meeting, and it was between me, and then it was Bart also, and another colleague who's intensely working with us from the ETRO department, which is Jeff. And then we started developing ideas, and we started thinking about how to tackle the problems. And at first we had a master's student then tackling the problem, which is Taylor France, for 1 year. And by that time we had gathered enough data and enough, let's say, proof of concept to be able to go for a full funding with a full consortium of people, in which the orthopedic surgery department of our hospital was also involved. And with this consortium that you see here of academically inclined people and some people from companies, which are assisting also for obtaining the funding, we actually got it for this SARA project about 2.5 years ago. And this is what's going on now. And it consists, of course, of a technical development, because it's a lot more than just clinical. But and this was the unique thing about it. We also had incorporated some preclinical and clinical assessment immediately of the developed techniques. So this means that we're assisting the engineers and the computer scientists in developing what we want, and we're giving immediate feedback. So I'm trying it on, then I'm telling like Taylor or Bart, I'm telling, well, I want this changed, I want this to be different. And then they change it immediately, we can try it on again. And so there's this real close feedback loop between us that that I feel is quite unique. And I have felt that when talking to companies, etc. So I will now leave the word to Bart, who will go over the technical development that we made in this project.
Wonderful. That's really great. Yeah, and that close tie is just so key. We'll come back to that at the end, and we'll talk about that a little bit, that feedback flow. So take the stage, Bart.
Good morning, afternoon, evening, everybody. Yeah, in 10 minutes I need to focus in presenting tech. Overall, the problem is quite simple. You know, you just want these holograms in place on the patient, nicely registered, with all kinds of feedback and so on and so on. Just in one slide, what is not going to be the main story is this this actual rendering and segmentation and so on. What we do is we have pre-op medical images, CT, MR, and so on, and there is some deep learning to get accurate segmentations of the different anatomical structures, like you see here for the brain. And then, of course, this all needs to be downsampled, because the HoloLens cannot run these very nice 3D models which we generate. And in the end, we just have visually appealing, pretty accurate, but low poly 3D models. That's all fine. After that, we worked quite a lot on intuitive manipulations because, you know, it's very easy to control whatever with the HoloLens with speech and gesture. But if you are in an OR, you need to realize that it's quite a noisy environment and that also surgeons don't want to put down their tools, put their hands in the air and start gesturing for half an hour. So we really need controls which are super easy and also quite precise. But let's not go into that, but let's go into what is in the next slides, which is what we actually did to accurately register the 3D holograms with the patient. Because we want in the end these holograms, or in this case anatomical structures, we want them to remain well in place on top of the patient, within a pretty high accuracy. So at first we basically started doing what everybody was doing, right? Quantifying how good or how bad the HoloLens is or was. We started to see all kinds of numbers and we just verified that. But pretty soon we then went for markers like the Vrije markers you can print and using the Vrije libraries and so on at some point, but by now we all abandoned that. But at the time, what we had was what is here. So if you just use the HoloLens out of the box, we had errors of, like, in this case, in this setup, 2 to 4 millimeters. Of course, can be much more in certain settings, but in this setup, we had 2 to 4 millimeters errors. And if we used the Vrije library, we were, like around 1.5, which was actually the same as using active mapping of the HoloLens at the time, but much faster. The active mapping was suffering quite a lot from significant latency, which was not nice during the procedures, and the Vrije tracking was much faster. But this is just to introduce what we at the very beginning tried to do. But when you go to the next slide, this is the same. This is the same, but numbers for surface point localization, where you see that in the end the majority was within 2 millimeters, but we thought that this was still not good enough, that this could be better. Plus, we had the issue that we needed to bring these markers into the OR all the time. And you need to clean them, sterilize them, and so on and so on. So then we looked into how can we get the accuracy of the tracking or of the spatial mapping even better than 1 or 2 millimeters. But we were definitely not willing to give into the principle of inside-out tracking. Because as soon as we would add additional cameras, it would work to get it much more accurate, I guess. But that would not result in a portable, cheap solution anymore. We were saying all the time, we do everything from within the HoloLens, and we can replace, to a certain extent, a surgical navigation system, which is costing hundreds of thousands of euros, probably. We can all replace that by an app in the HoloLens. So bringing extra cameras in the operating theater was not what we wanted to do. Pretty soon, we actually went for tracking infrared markers from within the HoloLens. Why is that? Because current neuronavigation systems are already using infrared markers. All the equipment is actually equipped with infrared markers. You see this pointer here and so on, which are used by the neuronavigation system. So By using the infrared markers, we did not have to bring any additional stuff in EOR. We did not have any additional issues with sterilization and so on and so on. And we also learned pretty soon that actually the field of view of the infrared camera in the HoloLens is much bigger than the field of view of the RGB camera in the HoloLens. So we could actually, by tracking in the infrared domain, we could actually have a much nicer use case where surgeons did not have to gaze all the time to the specific point we wanted to be tracked and so on. So then we wanted to evaluate how good is this kind of tracking, because you know everybody is telling us you are never going to use this kind of HoloLens in neuronavigation because you need sub-millimeter accuracy. We are always telling that that is not true. It depends on the application. Also right now with the neuronavigation system, you don't have sub-millimeter accuracy. And even if you would have, you still have soft tissue deformations like brain shift and so on going on. Anyway, what we did to evaluate against the golden standard is we used Vicon motion capture technology. So we went to a lab with a ring of high quality cameras which can track the Vicon markers within less than 1/10 of a millimeter. And we mounted actually the HoloLens on a robot arm. It's a pity we don't have a nice video of that, but we were moving the HoloLens around on this robot arm through the space to have reproducible trajectories in order such that we could compute all kinds of standard deviations and whatever. So all this setup led to the results which are here. The left is what you had before, like 27 millimeters on average, translational error in tracking the tools during surgery, and now we are at 0.78. So by using the infrared markers on the tools, on the drill, on the patient, we have everything within less than 1 millimeter at 15 frames per second on the first generation HoloLens running. Because it's important to note, we still don't have a new HoloLens which we are using for all of this. Having this actually gives us the baseline performance we need to do all kinds of trials with phantoms and with patients to check in how far this accuracy is also observed outside of the lab experiment, and in how far the human factor, for instance, in the procedure contributes to additional errors. So I guess Johnny is gonna take the floor again to address that in the next slide. One more, sorry. Besides positional, there is also rotational error. Very often we had errors of 15 degrees and more in the tracking the orientation of our tools without using the infrared markers. Right now, also there we are below 1 degree in tracking the orientation of tools, drill, and so on and so on. I guess that now really concludes my part. So back to Johnny.
Okay, so it was quite a relief to see all these numbers check out what you actually experience, and that is if you actually use the infrared tracking on the HoloLens, that you have a feeling that it's really the virtual image is sticking onto whatever physical image that you're tracking. So this checks out, and indeed, of course, it needs checking out that it's actually useful for what you do in the clinic and in clinical trials. So in the beginning of this project and even beforehand, we defined a number of trials. They called us ambitious, and in retrospect, we were to define all these trials to perform them in 2 years because we weren't able to, which was in part also due to COVID. But I think one of the important things is that we at least have approval of our ethics committee and of our federal authorities to go ahead with these trials. And one of the things that was limiting them was the fact that I wanted to see and be 100% sure that whatever software and application developments that were done, that they were really on point, because I didn't want to have to change the application or change the application after every so much patients, because that way you don't get any you don't get any good results. You don't get any definitive results, at least. So, but the things that we could do already beforehand were the phantom trials, so the preclinical trials in neurosurgery, so on intracranial drain placement, on spinal fusion, which are running right now, and in orthopedic surgery using directional drilling mainly. The hip arthroplasty is not yet done either. And then for the clinical trials, we did perform some experiments in drain placement, but results on this are inconclusive. So I won't go into detail on this. But I think the results from these preclinical trials are really very interesting, because the main thing that we wanted to address also is to show that the HoloLens or an augmented reality assistance can actually flatten the learning curve that you have. So this means that it could have an equal effect to training for some procedures, that if you give it to people that are less trained than other ones, they would perform equally. That's one of the things that we wanted to achieve. And of course, each of these research questions demands a different setup. So, but let's first go over, oh, that's not in its place. Let's first go over the phantom trials. Well, it is in its place, because it's a bit different from what Bart actually showed, because it goes to show that whenever you get a patient that requires some intervention, let's say a drain placement, and you have a scan from this patient, how do you go from having this patient scan in the emergency room to actually having the representation on in the correct spot in the OR? So of course you need the segmentation, that's one thing, but of course you also need to have this segmentation or these 3D models actually rendered on the HoloLens and then register. So this whole pipeline is also quite a difficult thing to tackle. It's not just some logical thing that happens on its own. It takes quite a bit of work. And this is something that we have achieved already. So we can actually go ahead with our clinical trials right now, which we have put on hold due to the COVID situation. But so let's first go into these phantom trials that we did. And the first one is in the orthopedic surgery department, and it's on so-called directional drilling. So when you're an orthopedic surgeon, you quite often have to drill a bone to put in a screw in a certain direction. And you know, this trajectory through the bone, it takes you from an entry point to a certain exit point, but very often, almost always, you don't see the exit point. So you have to kind of have a feel for what angle you have to take. And this takes quite a lot of experience. So, and there are actually three main types, main ways to be doing this, of guiding what direction you're drilling in. You can do it blindly. So where you feel, you eyeball it and you think this is the right angle and you just go ahead and drill. And then you need to estimate the correct depth also, so that you don't have an overshoot of your drill. Another way of doing this is using what they call proprioception. So it's your sensation of your body position. So this means that you feel over the other side and you put your finger where you want to drill towards, and then you go for the drill. And apparently feeling it with your other finger helps you in targeting your drilling. Of course, you should take away your finger at the right time so you don't drill into it. And then, of course, there's the augmented reality guidance that you can have. So what we did, we equipped a log with a certain number of entry points and exit points, and we showed these to the participants on a slide. We show them this, and then we show them this, and then we told them, well, you need to take the drill and you need to drill this hole into this trajectory, and that's where your entry is. And you have three sorts of ways of doing that. You do it blind, you do it while you're touching the exit hole, and you're using augmented reality guidance. And one of the more interesting parts of this experiment is that we had the ability to compare between students. So this is actually, you know, like let's say regular people, they have some feeling with medicine, but they have no surgical experience at all. Maybe some building experience that we don't know, but they have no experience in surgery. Then we have the surgical trainees, which are the assistants or the residents, and then the experts, which are the specialist orthopedic surgeons. So using the AR assistants, we equipped the drill with the infrared tracking device that Bart just explained. And then they had this guidance. It's not really completely on point. And this is, you will see this in a lot of pictures and videos on the HoloLens. This is because the set-off of the camera compared to your eyes is a bit different. So this means that what you see is actually in the right spot, but what you have photographed is not, or filmed. But anyway, if so you go for the target hole, and then if your angle is off, then it's red. If you start approaching it within, I suppose, 5 degrees or something, it becomes yellow. And then when it's green, it means you're fully correct, and then you can go ahead and drill. So what we then measured is the target error and the angular deviation, which is calculated in this way. But let's not go into the angular deviation, and not only because I don't understand this equation, but also because the target error is actually a lot easier to understand. So this is just the distance between the supposed target and the target where they actually came out. So this distance here, you can map this and then compare it to all the others. So, and this is when you plot them all the target errors using the 3 techniques. This is not saying much, this scatter plot, but in the next slide, it will become quite clear. So when you have people, so any people, this is any comer, so the experts, the students, so all of them taken together, have them do it blind, and you will see that, you know, you have a lot of outliers. You know, there's most people come in the right spot, but still, you know, it's a centimeter, so there's quite a big error, and you have a lot of outliers. Even using the proprioception, you get even more, you have the impression, and using the augmented reality assistance, there's a lot more precision and accuracy. So it's a lot more centered around the spot where you need to have it, and there's a lot less outliers. There's almost no outliers. And this is also clear when you compare these 3 techniques, and you see here, so the mean target error, you see that for the augmented reality, it's a lot less. This is also statistically significant. Let me just move my screen. Yeah. And this is, yeah, so this part is the angular deviation. So let's just skip that, because it gives the same message, it conveys the same message as the target error. So this is a bit more easy to grasp for me. So you can see that in numbers, so the error, the mean error between the target that they wanted to reach and the actually reached exit hole was 3.5 millimeters approximately, compared to 7 or 6 for the blind or the proprioception technique, which is clearly not better than just doing it blindly. And then what's also quite interesting actually is that the difference between masters for this simple procedure, let's say, so it's not as complex as anything that an orthopedic surgeon would do, but if you compare this to trainees, so assistants, specialists in training and actual specialists, you don't see any difference. You see the same difference, that it's better when using AR compared to blind or proprioception, but apparently doing this sort of thing a lot doesn't make you any better at it, which means that it's actually a limitation of the technique itself, and that it should be improved upon with a supplementary technology like augmented reality. So this is master students, trainees, and experts for your information. So when we look actually at the statistical analysis of what actually makes the difference, and you look at whether the experience, so this is the difference between the master students, trainees, etc., makes a difference, you don't see any statistically significant difference. But when you look at technique, so whether you use AR compared to the other ones, it does make a statistically significant difference. So these results are quite telling. And this was done in the orthopedics department with under guidance of Thierry Scherling. So I won't give you full details on the how many patients, how many subjects, etc. But this is one of the studies that I guided myself, and it's on the placement of intracranial drains. So the goal here was to compare the placement of these drains freehand. So the technique that I explained in the beginning, using this anatomical guidance to the augmented reality guidance. But we also wanted to see what training does in this respect, how training, so training meaning the actual explanation of how you do it, what landmarks you should look for, and what targets you should try to reach, how it does. So how did we set this up? We had test persons which are uniquely medical students, so people completely oblivious to how you put in a drain. They know where the frontal horn of the lateral ventricles are located. And we show them that as well on a 3D image, but we don't give them any further guidance. The rest is up to them in the beginning. So we randomize them into two groups. One of the groups does the drain placement without the use of AR, just freehand, and the other one with the use of the AR. And they each place 4 drains in 2 foam models. So one's before training, one's after training. So we had 10 people do it without AR, 10 with AR. So I should tell you, of course, that we have a lot of these foam heads lying around here, and it was about 80 of them that we had to scan eventually. But the results are very interesting. So the sequence of procedures was that pre-training, so the people without AR placed 4 drains, so in 2 heads, left and right. And the people with AR, they also put in 4 drains each. And then they all had a training session that I myself gave. So I just taught them how you normally do it in a patient, using actually the slide that I showed earlier. And then post-training, they did the same again. So they put in 4 drains, and the people that didn't do it with AR, they stayed freehand, and the other ones, they stayed AR. And for the people that, so this is the training that they got. So the people with AR put some drains in under AR guidance, infrared guidance, as you can see. Those freehand just put it in freehand. I gave them the training, told them the distance, told them how to mark the exact spot, what to target, etc. And then they did the same again. By the way, we did a full examination of their psychomotor abilities using a laparoscopic trainer and all of this, and their evaluation of their 3D vision, just to cancel out any outliers, because some people just can't see it, but we didn't have that problem. So, but it gave us a nice classification to see who would be better able maybe to perform freehand, etc. So this is what we did. And when you look at the results, so I have them statistically, of course, at the end, but just to give some images. So what we actually did, we have the foam heads, the base here, and the ventricles were defined on basis of this MRI. So as soon as they placed their so-called drains, which are actually lumbar puncture needles in this case, inside the foam head, we then scan those and then refuse them with the MRI, so we can see what the relationship with the ventricular system is, to see if they're, so we also did target error, see if they're actually deviating and at what distance. But for the clinical results, we fused it with the MR to see the ventricles. So these are the ventricles right here. And so these are some freehand pictures. I have some of those that are quite worse than this one. But this is just to give you an idea. So they have a general idea of where the ventricles should be located, but you know, they didn't receive any training. You can't blame them that you put this in at the completely wrong spot. But honestly, these are the sort of scans that you sometimes see in the clinic as well, because you can sometimes get completely disoriented as to where the direction should be, and you get these sorts of results. So after they had training, results improved, luckily, because you know, it shows the quality of the training as well. I think it would be a bad thing if it wouldn't improve after training. But anyway, it's not perfect either. So, you know, there are more drains that are not actually in the ventricle. And then, so these are results that are all not so surprising, because they're completely unexperienced people, never put in a drain, never even seen an operation for a drain, and probably never even heard of this type of thing before coming here. But then we have the AR people. And when you look at these images, and when you look at the videos as well, you can see that almost all of them, well, it's not almost all, of course, I select some images that are quite telling, but these are the general gist of the idea of the results that we have, that, you know, just as a reminder, these are people that have never even seen a ventricular drain being placed. You put them on a HoloLens, you shortly explain them how they should point and click on stuff, and then they are guided by the whole system that tells them to put the drain in this spot, and they are really on the spot.
Hey, Johnny, I want just briefly, yeah. So one of the questions that's been coming up is how much training with the HoloLens had to be given, even on the experts. You know, if you took the expert from the novice, from the, you know, the middle expert that you had on that slide, is it a thesis that with a little bit of more training with this technique that the experts will become even better, or do you think it's going to stay level, like the expertise? So how much training with the HoloLens was required before you did this, or was there no training with the HoloLens?
There was some training with the HoloLens, but this was equal for all. So
on that previous one where you did the experts versus, yeah, equal training, on the previous research,
yeah, it's on the orthopedic test. So the training on the HoloLens is really quite simple. They're just taught how they can manipulate things, how they do the typical bloom gesture and the point and click gesture, and how they can drag things and move them around. But that's it, really.
And that's it. And is there a thesis that the more training that they have, and when you move to the eye tracking, it will get better? Or
yeah. But to answer this question, you should do this sort of experiment like we did here with the drains, but including the experts. And for this type of thing, drain placement, we feel it's too simple of a procedure to do this sort of thing. But we have this planned in for spine surgery, for pedicle screw placement, because this is something that really requires a lot of training. And we want to see so I think in this respect, so I'm not showing these results here, but these results will probably show that you flatten the learning curve enormously, so that normally it's quite a difficult thing to put in pedicle screws. It takes a lot of training. And with this, it will be easier. So even novices will be able to put them in correctly because of the guidance. And I think, so for them, it will go, you know, if they put 2 out of 10 right, it will go up to 9 out of 10. And I think for the experts, if they put 8 out of 10 right or 9 out of 10, they will go up to 10 out of 10. But to determine this, it's a whole different setup, and you need a lot of test persons. But we have this planned. We have some very large cadaver studies planned in the future. In the near future. So this is when you take all the, so again, this target error, so the distance between the planned target and where they actually ended up, this is plotted here on a 3D axis system, just to give you an idea. So let's say that this point in the center is where they should actually end up. And this is a scale, it's, let's say it's in millimeters. So this is 2.5 centimeters. So this is freehand before. You can see that some people really, you know, they went all over the place, like you can see here. After the training, it got a bit better. And when you look at the AR results, you see, you know, the same message like the scatter plot that I show with the log drilling trials. So it's a bit of the same message. And interestingly, and this is maybe more clear from these results, So this is the target error, the mean target error. It's about 3 centimeters to 30 millimeters with a big confidence interval, like you can see. And this is really huge. And after training, so what you see here, this transition is the effect of my training. So, or training in general, just being taught how you should do a certain procedure, if it's such a simple procedure, and they perform it well, which in this case, they of course did their best to. This is the difference that you see. And what you see here, AR, untrained, is also this same group of people just randomly got the, got randomized in the HoloLens arm, and they got these results. So the difference actually between the untrained and the trained is not significant. It's actually the same. We were not sure on these results because the problem here could have been they also received some training in the middle. So they first did it without any training, got excellent results, but you know, we wanted to homogenize it or teach them a bit what they were actually doing. We gave them a training here, but I still told them you need to look for the augmented guidance. So, but it's just that when something is completely off and you're drilling in a really completely wrong angle, now you will know and you can correct for it yourself. So this could have distracted them a bit, maybe because they were aware all of a sudden of this extra information. But there's actually no difference. You can't state that there's any difference between this.
All right.
So
I want to gracefully move you to Q&A because we're getting to the end of the hour.
Yeah, so but I'm finishing up here.
You go. All right.
Okay, so it was actually my last slide.
Oh, I'm sorry.
So,
yeah, there you go.
Here's where you see all the comparisons, and this is where the significance lies. So if you compare freehand, untrained to the AR, trained or untrained, doesn't matter, or the freehand trained, then there's a really significant difference. So this means that these are all good and this is bad, and you improve it. Either you give training or you give a augmented reality guidance, and then you don't even need training. Whether this applies to more complex procedures, that remains to be answered, of course. But of course, this is the hope that that we will be able to do this in the future, and technology is quite ready for this. So this is just to finish up a video of the RTBF, which are the French, which is a French TV broadcaster who came to film in our OR for another part of the project. It's where we display the tumor location on top of a patient's just to show his deep anatomy, and so that is displayed in the way that you see here. And we're comparing this speed of working. So you just put it on and then you plan the incision and you plan the craniotomy, you plan where the tumor is going to be. And we compare it to the standard navigation just to show that it's a lot faster and a lot easier to grasp for people in their early stages of training, because you just get the 3D image, you can just walk around it. So I will conclude with this, my presentation, and thank you for your attention.
Fantastic. Really, really insightful, and the research is so exciting. So I'll push us into Q&A. I think you can both stay maybe a few minutes after. But the first thing that I think we'd like to hear about, and maybe it's to you, Bart, on this one, is the pipeline. Like that notion of someone shows up and their imaging has to end up in a 3D model. How fast is that pipeline? And are we getting close to fast enough for emergency situations in order to deliver that?
It depends on how fast an emergency situation has to be. No, so there's a lot of work that needs to happen. So there needs to be CT, MR, whatever medical images. And these imaging, that takes time on its own, but it's part of the standard patient assessment. But these images need to be processed to generate these 3D models. So it means that all the anatomical structures need to be segmented. And in medical image segmentation, everything goes fine and automatically and fast and so on, as long as there's no pathology. And as soon as there is pathology in the images, most of the time we need to rely on pseudo-automatic tools So we
Well,
need to.
and one of the reasons I asked the question is because when you think about sending this to the field, you know, like out in the field where you can send the HoloLens, but you have to have connection to cloud in order to do the processing potentially. So I was interested in that. You know, there's so much promise here. So if you were trying to send it to the field, just a comment from either of you about, you know, the future.
If you send it to the, there is two aspects. The one aspect is all the I saw questions on that as well. All the computations related to tracking and rendering and everything we do on the HoloLens first generation on the device.
Right on the device, great.
Right on the device, the infrared tracking and so on. So for that, there is no cloud or whatever needed.
Super.
But all of our applications depend on the existence of preoperative medical images. And that is, of course, an issue if you are in a remote area and you just have a HoloLens with you and somebody else at the other side of the world is trying to talk you through a procedure with the HoloLens or something. Then you will not have these medical images.
Okay.
Of course, suppose over there you would also have a scanner and so on. You could transfer them and then they could be segmented to generate the 3D models, but that takes a bit of time. Depending on the exact pathology, this is automatic or pseudo-automatic, or there is the hurdle right now, or one of the hurdles.
So the next one is about the equipment, wearing the equipment itself. And Johnny, I don't know, when you're wearing the equipment, do you need additional equipment when you're wearing the HoloLens? You have to take it off, put it on, you know, so that notion of how clunky is it and how do you keep it sterile when you're using it? Do you have any comments about the usability from equipment perspective?
I do. It's not perfect. It can be improved, definitely. And the second generation HoloLens is a lot improved. It's a lot more comfortable because the weight is more distributed on the back and the front. But for sterility, it's not actually too much of an issue because your face anyway is not sterile. So you have it on, you're not touching it, it's not touching anything in your surroundings. And also for the controls, because you have the voice and the gesture recognition, so that's not too much of a problem. But as for now, so we tested it mainly for short procedures like this drain placement, so you would have it on max a half hour. And for the tumor incision planning thing, you would have it on for the first part, which is like an hour, and this is definitely doable. So there are things that need to be solved, which is the comfort, and it's a lot improved in the second generation, that's for sure. Another thing that needs to be solved is the battery life, which is also too short to really keep on your head the entire time. It's only, if you use this application after an hour and something, your battery will be dead. But it's not an issue that I would worry myself too much with now. It will be, you know, because you know that these sort of things in the future, they will become more comfortable, they will be reduced in size, etc.
And we'll launch right into the questions from the audience, but that was one last thing that I just wanted to give you both a moment to say, if there were things like the battery life or other things that you hope that other brilliance brings to the table, is there any like really high barriers that you're seeing? Or, you know, for some of our talks, people are talking about we need more haptics, we need more other things. Like in order to make this really viable, battery life is really important, right? Yeah. Stick it in your pocket, plug it in so it doesn't weigh your head down, right? But are there other areas that you're just like, we got to work on this, folks?
Well, of course, there are many areas, but, you know, and that's the collaboration that we have. If there are still problems ahead of us, then we try to develop this into a project and try to tackle all these problems. So these are some things that we have defined. I saw it appear in the Q&A somewhere also. So
yeah, we can move right into that too. I just wanted to give you a chance to say, hey, these are the really tough areas that we haven't addressed yet. Yeah,
well, I don't think it's much haptics. It's more you know, improving the accuracy and reliability of the positioning of the tracking. That's one thing. And then it's a different issue altogether of you know, the historical imaging. So in reality, you should have a way of updating the information that you have. So reworking the imaging information that you had beforehand on basis of certain data that you can gather during the surgery. That's actually the main concept of a new project that we're launching in right now.
Oh, that's great.
It's an issue for the navigation as well. It's not exclusive to the HoloLens. It's just a neuronavigational issue.
All right, well, let's get into the Q&A from the audience because there's a number of questions. If you guys can stay for about 15 more minutes. The first one is actually asking about the tracking and the visualization, is if the IR markers are solely on the HoloLens. And if you want to see these questions, guys, you can just hit that Q&A and they'll come up for you as well.
Yeah.
So that one's directed at you, Bart.
Yeah, and so I already said, yes,
Yep.
that's
Yes.
the whole goal. We can do it 15 frames per second with low latency on the HoloLens, and in parallel a visualization thread at 60. So
Yeah,
why would we bother streaming elsewhere,
yeah,
and having cloud and everything if it just works?
And okay, so the next one is, oh, go ahead, sorry, excuse me.
Yeah, I wanted to chip in on this. So maybe the question was also, I can't really seem to find the question itself, but anyway, the IR markers, oh yeah, visualization solely done on the HoloLens, because what you see in some publications is that the HoloLens itself is actually tracked, equipped with tracking markers, and this is being registered by the camera. So in this way that you can track whatever the HoloLens is rendering, but that's not what we're doing. We're having
the opposite.
Yeah, it's actually the opposite. It's the HoloLens that doing inside out tracking of the infrared markers, which to my knowledge has not been done.
Great. And then the next one is from Greg, and he's asking if you've used any finger tracking solution devices. No, not yet, or not. Are you thinking about using it? Yeah, no. Okay.
No,
so
because
manual.
actually the finger tracking on the HoloLens is quite sufficient for the applications that we have for it. One of the issues is Bart didn't put in this video, but so one of the issues that you always have with a HoloLens is the occlusion problem. So this means the image is actually rendered right before your eyes. So when you go, but it's projected at a certain depth. And when you want to occlude it with your hand, for example, you want to cover it up, it's still projected on top of your hand, so it's not occluded. So to solve this problem, I think the best way at this point in time would be what they call a pseudo occlusion. So this means that when you move your hand, it has to show your hand in VR as well on top of your actual hand. And doing this, so with a rendered point cloud, we have a video of this, you get really quite impressive results that show that this pseudo occlusion really works, first of all. And second of all, that also shows that the finger tracking can be very, very accurate. So it's really quite impressive. So for our use, it's really sufficient. So no research on that.
Super. And the next ones, and you guys can pick and choose these if you want to, is talking about internal structure, the deformation of internal structures. Do you want to speak to that one?
Yeah, that's a very interesting question. This is an issue we are facing as well. This relates to the whole problem that if you have preoperative images, they are outdated by the time you open the skull. So as recent as yesterday, we did submit a new funding application for exactly going into this.
Super.
Right.
So,
but
yeah, sorry.
Again, the issue is you can track brain shift and so on with additional cameras or with additional whatever sensor modalities. But we want to be very careful to keep a portable solution and not go and rely again on a full neuronavigation system or a system which remains bound to the operating theater. So the question is there, how much can you do directly from the RGB and depth camera from the HoloLens?
It just seems like you're going to have years of, and if we have an OR that we can equip with additional, great, you could do this, but let's keep our eye on the single component.
Yeah. For now, that's an important track.
Yeah. And the next question is about the difference between the 2 and the 1, the HoloLens, and whether you expect a huge difference.
Yeah, so we actually tried it a couple of times, the HoloLens 2. And actually, the comment of a lot of people is that the representation of images, mainly on the edges, is not as accurate as it is on the HoloLens 1. So if you have a lot of physicians try it, then they would prefer the visualization through the HoloLens 1. But it is a lot more comfortable. It has eye tracking, and it has more processing power and stuff like that. So we're still waiting for the arrival on that. The Microsoft only recently opened up the research mode on the HoloLens 2. So having it before that wouldn't be very useful. But so we still have to explore how our application fares on this second generation.
Yep.
Okay. The next couple are a little bit, I think you already went into Lisa's question a little bit on the percentage results, unless I misunderstand it. So if you want to take a look at Lisa saying, do you have a percentage or result specifics from the AR equals before? So I'm not sure I understand that. And yeah.
I think she needs to clarify her question.
Yeah, let's try that. We'll move forward. With the next one saying they didn't understand how you correctly synced the DICOM. Is that just something that they could read about, or do you want to take that question on?
Now we can very briefly say something. Huh?
Sure.
So from the DICOM, if you can generate 3D models out of it, if you have that, you need to overlay the 3D models accurately on top of the patient at first. And there you can either do a manual procedure, so using the HoloLens, to use controls and gestures and so on the HoloLens to move the 3D models in place. And once they are there, once you've moved them in place, they will remain in place thanks to the tracking. Either you would have some automatic procedure which matches the 3D models with the 3D anatomy automatically. That we don't have. We are, of course, looking into that. That is very fine, very nice. That's a very nice challenge, but we don't have that working. So for now, it's manual.
Yeah, that's good insight. And I'm going to skip down to like the eye strain question. Eye strain, headaches, things like that. Are you, maybe Johnny, you've used this quite a bit. What is your comment around that? How are you doing with that?
Yeah, my personal comment is I don't have anything of the sort at all. Never had any feeling of eye strain or whatever, but I have had some people complain about this also during the student experiments that we have. And apparently that's because the HoloLens renders this image that's projected in front of you at a fixed distance. So as soon as you, and it gives a certain sharpness that we would normally see at a distance, I'm not sure, I think it's about 40 or 50 centimeters, depending on how Bart or his colleagues would set it up. But of course, this becomes annoying if you move closer or further away, because all of a sudden the sharpness or the focus doesn't change where it should for your vision to be comfortable. But I think for the application that we use, we always stay the same distance from the patient. You can walk around it, but you keep the same distance towards the object. So your focus doesn't need to change on this. So I think that this problem of simulator sickness, which is indeed quite often seen in VR mainly, is a lot less evident when using AR, when using this device.
So we have a couple of cost questions in there that I think you could take on together. One of them is about the sort of the full cost of the whole thing, and the other one was, taking your research and adjusting it to do something in particular. So you showed the drilling, but to use it in other ways, is there a cost around that, or do you see other scientists taking it and medical experts taking it and using your research to do other procedures? So I think those are both cost related. They were asking what's the effort, how much work, how much cost in those kind of areas.
First, hardware cost. Hardware cost is super low. Huh?
I think it's an overall cost, like that. Yeah, the HoloLens, that cost, yep. People can sort of look up, but the overall cost of doing this, creating the application and using it. Do you want to comment on that?
Yeah, so everything we have is done during a research project of 2 years by a rather small team. There is many people involved who give advice or who share their opinions or who test things, but all of this, in the end, has been programmed by 1 or 2 guys. And they did not spend 2 years in one application, because we have and the drilling and the tumor tracking and the drain placement and so on, right? So overall,
it almost felt like
has been,
yeah, framework
has been
question.
quite
Like, are you
efficient.
creating a framework that people will be able to use to
Well,
extend, or yeah?
Well, we are at least building a framework for ourselves, because indeed we are expanding to other use cases.
Yeah.
And we are using the same registration technology and tracking technology and so on. But we might need to provide quite custom visualizations depending on the specific use cases. An arrow pointing somewhere will not always do the job, right? That's to be seen.
Yeah.
Okay. Yeah.
So just as a general answer to that question, we don't know. So we can tell that HoloLens, if you use the Enterprise Edition, costs 5,000 euros or dollars, which would be approximately the same. But then what is the cost of all the work that we put in? And if you commercialize this sort of thing, it should of course be cheaper than a navigation system, which is, you know, quite pricey. But what the actual cost should be, you know, the determined after some market research, etc. And this is something that's being done currently, but I can't answer you with that. I'm glad that we don't have to look into that problem too much.
That's okay. Yeah, they're like, how much? What's it going to take, right? So that's a good thing to hear.
Right.
So there's a couple other, one question in particular is interesting, is there's so many hands in the OR from Willie. Can the HoloLens tell the hands apart? And related to that question, I wanted to ask about whether or not you expected multiple people to be wearing the HoloLens sort of collaboratively someday. So, but the first is, how does it tell what hand, or do you have any trouble with that at all?
No, it just tracks the hand that's in front of it. So this works quite well. This is actually more a question that should be directed at Microsoft, but they developed this quite well. So if it's detecting your hand, and the HoloLens 1, so the 2 is actually doing a better job of detecting any movement. The first generation is quite restricted to this blue movement and this typical tap and select movement. But the fact that they turned this off in the second generation made it quite hard for people used to the first one, because you're always doing this and it's not recognizing you anymore.
Well, to make sure we get Willie's question, I think when he's thinking about multiple hands.
Yeah. So
yeah.
No, that's not a problem. That's not. Or when you're covering your. Well, actually, so the hand tracking is only of use when you're doing any selecting or stuff like that. But when you're actually doing the operating, it doesn't recognize your hands. It won't. So seeing your hands won't interfere with the whole thing. And then, so the second part of the question, so this is actually also part of the new proposal that we did, because the idea is that this, so imagine that you have the physical world of the patient, the OR, the nurses, the surgeons, the anesthesiologists, everybody's there. And there's the virtual worlds of the patient's anatomy, and any guidance that you could have. It could be any virtual person that's actually there from a distance. And so these two should be merged, and they should be approached from anywhere. So this means that the surgeon can put on a HoloLens, for example, and see, of course, the actual situation combined with the augmented situation, with the virtual information. And any other person in the OR could have the same opportunity, but they could be, for example, looking at a screen and seeing this exact information. You should be able to switch, putting off the HoloLens and going into the operation microscope and seeing the same augmented reality that you had. It's just, it should be a smooth transition for any device. And any device that you look at, any visualization device, be it even a VR headset or an AR headset or the screens in the OR, should be able to render and the physical and the virtual information in the correct spot. So the tracking should be on point of the spatial mapping should be on point. So this is another problem that we would like to tackle in our new project.
And actually that comes up in 2 or 3 questions. Like I want to mention Florina and Lisa asking questions about, are you wedded to the HoloLens, and have you thought about other, you know, VR see-through devices and things? I think that's very related in the notion of, have you done any work with other AR headsets or VR headsets?
At the start of our work, actually, the HoloLens was kind of the easiest available and most suited device.
Yeah, the best thing out there, right?
The best thing out there, but it still has plenty of downsides for what we want to do. So of course we are looking at alternatives. Technology-wise, yeah, this is all built in Unity, and tracking stuff and so on, not in Unity, but is platform agnostic. So we are still quite confident that this can be translated to any other platform.
I was going to ask game engine, so Unity is the game engine. Cool, okay.
But unfortunately, we don't have access to many of these devices out there.
Yeah.
So we have another question. Oh, go ahead.
Just a quick reply also. So I have tried the Magic Leap and the HoloLens 2, and if I would have seen any dramatic difference with the first generation HoloLens, then, you know, we would do our extreme best to get this into our project, because the second generation HoloLens actually came out while we were doing the project. But I tested it, and and we told to ourselves, well, this isn't, you know, the drastic improvement that it could offer, so we might as well develop further, since we're trying to be platform agnostic on the HoloLens first generation. But there's nothing on the market currently that's, you know, drastically better than what the HoloLens provides, which is still a quite spectacular experience, if you ask me.
So Lisa has another question, which is a good one. Do you have any idea how much this might reduce costs for patients and hospitals? Sort of a long thought, you know, like over time, once it's, I guess, assuming it becomes very standard practice. Do you see it as a cost reducer?
Yeah, of course it depends on the price point that you set it at. But I know that prices vary enormously between Europe and the United States when it comes to neuronavigation systems. But just to give you a quick idea, in Belgium, a neuronavigation system costs around 400 to 500K, so €500,000 or dollars. I think in the US it's up to 1 million, because, you know, prices are a bit higher there. And so you will never charge a software application that runs on a $5,000 device at such a price point. So it will be a lot lower. And I think that can be a mission of this sort of project as well. Like you saw, that the students that have never done this sort of thing, you put them on a HoloLens, they put in a drain correctly. There are third world countries where the surgeons there don't have any of this sort of experience. They don't know how to put in a drain, but if they don't do it, then patients die, which quite often happens. So I think what this relatively low, if it remains relatively low cost, it remains to be determined, then it could be able to democratize medicine and surgery to some extent. So I think this will reduce enormously the price point, but of course the markets will adapt then, and that's an economic discussion.
And in this area, it's not like you're taking all of the other equipment out because you're bringing this equipment in. I mean, so I didn't know if you wanted to make a comment about that, Johnny. It's not displacement of equipment unless you're in the field and you don't have anything. Like you're saying, democratizing it and saving people that don't have, you know, sort of heavily equipped ORs, right? But I don't know if you want to make a comment about that. I think sometimes our audience will think about this as the solution into everything that you need in an OR almost, but it's additive at a price point that seems amazing for what it delivers. But I don't know, you know, if you want to make comments around what would anything leave the OR, you know, that costs thing associated with
Yeah.
that?
Well, so there's two situations that you can imagine. There's first the heavily equipped OR that has the peroperative CT or even MR scanning. You have the intraoperative ultrasounds to update your images. You have the neuronavigation system and all that. It becomes quite cluttered in the end. You have a big OR with a lot of machines in it. But then on the other end of the spectrum, you have the ORs in third world countries where they don't have a lot of equipment, but still need to perform sometimes the same types of surgery. So, and I think the HoloLens or any augmented reality wearable head device with heads-up display can be positioned in either of those two situations. It will serve a different role in both situations. So in the first situation, it would just increase the comfort and decrease the learning curve also of people in training, probably. And in the other situation, it will, simply save lives because there's no other way of navigating available there. You're muted. Wait, you're still muted,
Yep,
Julie.
there we go. Sorry. So I'm going to skip down to the last question from Catherine Beskar, and it's relating to adapting the technology to other headsets, only because I think the question here is interesting in that it's saying, is the work really tailored just to the HoloLens? Because, like Bart, you brought up that it's based in the Unity game engine, and we haven't really talked about the other sort of third-party components that are in it, and some of it's the special sauce here, but I'd like you to be able to comment on that question, the last question there.
Yeah, so it's Unity, and the more intensive processing is C++ stuff, but not using anything special, or not using anything platform specific, but using like the typical image processing libraries and so on.
You just get so many questions on that I know some of it's your special sauce, but I wanted to make sure.
But yeah, what I see in the chat also is like Project North Star being mentioned as one of those very cheap but very promising platforms. Yeah, that is one of the things we are also gonna explore.
Super. And
does it run there, and what quality do we get with this kind of platform?
I just want to do a little tiny bit of housekeeping, and then we can go back to this. Let me share my screen for one moment. And just there are a lot of people here, and I want to make sure that you know about our upcoming talk. So we have a couple of upcoming talks that are really going to be wonderful. In 2 weeks on the 21st at the same time, October 21st, 12 p.m. Eastern Time, we have a number of my fellow organizers of MedVR are going to get together and talk about MedVR. We get a lot of questions about it, and the reason why we think that talk is going to be really interesting is that we are going to kick off a 6-month learning series, and I think that's going to be wonderful for, and it's very intensive, and it'll be very useful, and it's also free, and it should guide people right into a hackathon that we have next summer. So I really encourage people, if you want to know more about MedVR and about that learning and what we're trying to do, that's going to be a great talk on the 21st. And then we're very excited that we have Dr. Navab, who is just amazing, who's going to be speaking on the 28th. So that one will be the same time slot, and that is very, very exciting for us to share with you. And I believe on the 28th, he is going to be joined by Greg Osgood, who's the chief orthopedic trauma surgeon in Toronto. So we're very, very excited by this. So that looks like it's going to be a really good talk. So if you don't know about these two individuals, they're tall figures in the field. So I just want to do my housekeeping and thank everyone for coming. And then we can go back and check the questions. And see if there are any others. I think we've come to the end of the questions. They're still asking questions about the technology, and I want to make sure that everyone knows that they have special sauce, that they're going to have commercial products. So that's one of the things that I think is very clear that's going to come out of this research as well. So I don't know how deep they want to go into all the specifics around the technology. And I want to give our speakers the last word. As we've gone over a little bit over time, we thank you very much for your amazing input and insights. And I just was interested in what you think it's going to be like over the next several years, or maybe, oh yes, in 3 years, my vision is the following. So just sort of wrap it up with your opportunity to give us last words if you'd like.
Last words.
Oh,
I'm reading very interesting things on the chat meanwhile.
Just for this talk.
Yeah, sure. Yeah, no. In my opinion, the critical thing missing right now is that the visualizations are outdated by the moment you touch the patient. And we really, really, really need to work on that, or the domain really needs to work on that. Of course, in certain centers, there is intraoperative MR and CT and so on available for very specific use cases. But also there, it takes time to process the images, to compute the differences, to update the 3D models, and so on. So even in that approach, we are not there yet. So for me, that's really the big challenge the coming years in this specific application domain.
What about you, Johnny?
I fully agree. Because I think one of the main issues is, so there are solutions to solve this problem of outdated or historical imaging, as we call it. But any solution that's offered now still requires an interruption in the workflow. And it's not, let's say, continuously updating the information based on whatever's happening. And I think this is something that should be solved. It's something that we defined. We won't disclose too much of it, but so stopping your surgery to do a scan and then restarting the work, and then by definition, you know, disturbing the anatomy again and changing it all up again, is just interrupting workflow and costing time during surgery. So if everything works out like we have planned currently, then we should have a really good thing to solve this sort of issue.
I just find it hard to believe that there isn't some super secret government project somewhere that you could just pipe right through your HoloLens and you can see everything live and overlay, right? But
maybe there is, but we don't know about it.
Yeah, exactly. You have to be super secret to know it, right? So.
Right.
All right. Well, we want to thank the audience very much and thank you both for your time.